Well, it's a little different the way I worded it. So I call it as optimizing mechanical thrombectomy. See, I wanted to drive home a basic fundamental. If a patient with a fever come, and if I believe that every fever has to be treated with paracetamol, whatever is the underlying cause, obviously it'll be disastrous. And I think we have to understand, can all strokes be treated in the same way, whatever the etiology is, So one has to look and see what are the variables that you'll get in stroke. The first variable is the location. You could have a branch occlusion, or you could have an occlusion of the internal carotid artery. And today we know that the volume of thrombus in both of these are very, very different, and the approach has to be changed according to that. Now, if it's a branch occlusion, it could be a soft, fresh RBC clot. It could be an organized RBC clot which has come from maybe the LA in a case of mitral stenosis, or it could be a fibrin-rich clot, or it could be an ICAD which has occluded. Now, if it is an IC occlusion, you may be having an underlying stenosis which has occluded, or it could be again an embolus that has parked itself at the bifurcation. So the question we have to ask ourselves, truly will one device work for all these etiologies, because angiographically they tend to look the same. If it's the internal carotid artery, that's the point of occlusion, it could be a stenosis, or it could be an embolic lesion that is parked there. It could also be a dissection, which I'm not bringing into this talk because you can pick it up on a CT or an MR. Can we differentiate the two? Often it's difficult unless you've got a history of TIA or there is some calcium out there, and technically it doesn't probably make a big difference in our approach. For example, in our center, what we do in all of them, we'll have a neuromax. We cross the lesion with a coronary wire. We take a 4 millimeter coronary balloon. We pre-dilate, and as we start deflating, we drive our neuromax across it. Now, this is an important step so you don't snowplow plaques if there is a vessel that is actually patent above. And then we take a soft angio. If there's clot, residual clot up there, we aspirate with the neuromax, not with the ACE or with any of the other aspiration catheter, because this gives us an amazing lumen to aspirate. For example, here's this 50-year-old male. This is the MR aspect score that we have, the diffusion aspect score, and the angio which shows an IC occlusion. You can say there looks like a critical stenosis there, but it's occluded distally. We pass the wire, you can see out here, and this is the balloon being inflated, the 4 millimeter balloon. We take the neuromax across it, and we find actually the vessel is occluded only beyond the origin of the posterior cerebral artery or the fetal PCA. Now we do a technique which we call the modified celumbra, which I will talk a little later. We have the microcatheter across out here. The suction catheter is right here. We inject and we see there is still residual clot. We go distal to that. We deploy the stent retriever beyond it or across it. We have the suction catheter now very, very close to the proximal end of the stent retriever. We suck through both the large lumen catheter in the IC or the balloon guide there, and we get something like this. In the end of the procedure, most of the vessels are open, but the posterior trunk is still occluded. We go ahead, repeat the same technique using the microcatheter, stent retriever, and the suction catheter, and we establish normal flow. At the end of this, what do? Ensure that your wire is across, pull your the sheath down, do not remove the wire. The result looks fantastic. You feel that probably you can leave and come, never do that. Keep waiting. In the next 10 to 30 minutes, if it is still open, you can actually back off and plan an elective stenting later. Otherwise, like in this case, you go ahead and stent. In our center, we use a double layer stent in all these acute conditions because we know that it kind of like a fishing net holds back a little bit of the residual thrombus, and we have a patent ICA and a vessel that is flowing. We wait for 45 minutes. This patient is now on oral aspirin 300 milligrams. If necessary, we give some tyrofuse, and after 45 minutes, we come off. Now, after this, we come to the branches. And like kids, you can get an RBC-rich clot, you can get a fibrin or a hard clot, or you can get an ICAD with an occlusion. Can we differentiate? At times you have a very definite history. You have a patient with the MI, you got a patient with cardiomyopathy, you got a patient with atrial fibrillation. The CT is crucial. It shows a hyperdense MCA. In our center, we do an MR for all of them. We always do an SWI purely to look and analyze the clot, and it will show blooming. There is nothing that is more accurate than this to tell you're dealing with a soft RBC clot. And often it will be in the distal, at the branching point, the distal MCA or the bifurcation. So this is how it will look. You have a soft clot there, you take your stent retriever, and as you do the fluffing technique, it will invariably open. You took an angiogram at this time, you'll see the vessel mostly open, and it will come out as you retrieve it down. And you get a great result. But why do we say you need a double suction even in this? The problem is in many, many patients, you will have a good ACOM or a good PCOM. And when you aspirate, what actually happens is, this is what happens. Your suction is really driving the blood out of the ACOM and reduces the suction quality enormously. Or in the PCA, it works this way. You can, and that's why you have to be careful, because RBC clots tend to fragment as you pull them down if you do not do this. So it's safer to use a double aspiration technique. So let me tell you, aspiration is like this. We have a microcatheter. We take the suction catheter over this, and we aspirate, and the clot comes out. Now, imagine a situation like this. You have a occlusion here. We cross it. We put a stent retriever. We take a suction catheter, bring it into the proximal 10 or 20% or 25% of it, and now do not take the stent retriever completely into any of these devices. Aspirate, pull out the microcatheter. So you got more space for aspiration. As you aspirate to both the sheath in your neck and through the aspiration catheter, you bring this out, and your success rate will improve enormously. For example, here is a patient. The M1 is hyperdense. This is the diffusion, but I want to show you the SWI. It shows this, the blooming that is seen on the ICA top. It is an ICA top occlusion of fresh RBC clot. And this is what the angio shows. You go ahead and do this double suction or the modified Solumbra technique, and you will get good flow. And in our center today, changing our practices, our reperfusion rate is crossed more than 95%. Here's the clot out there. Now what happens in an ICAD? Can we really pick it up? You may have a history of TIA. There will be no hyperdense vessel or blooming. You may see calcium sometimes in the vessels. Invariably, if you look in the angio, there will be other vessels showing some changes. It's never restricted to one vessel. One important thing is when you do the angiogram, you'll see good collaterals. This also was talked in the previous speaker. And collaterals, good collaterals are an indication of an underlying ICAD. Very often the vessel will be tapered and it will be in the mid-MCA rather than the distal MCA. Now what exactly happens when you do this treatment? You have an ICAD. We take the stent retriever across. Even if you fluff it, it won't open fully. When you take an angiogram, you'll get poor filling. You won't see it like the last one. When you remove it, the vessel will open partially, but the thing is, in the next few minutes, it will shut down. When you see things like this happening, think in terms of an ICAD, and the best thing here is not keep on putting a stent retriever over and over again, but to start infusing Tyrofuse. When you inject a 2B3A antagonist here, the vessel will open up. When it opens up, if you're happy with the result, back out. Do not try to get perfect results in an acute situation. Now take a balloon. If you still are unhappy, balloon dilate and see the result. If you're safe, back off. Stenting should be the last resort because it's dangerous to add a lot of antiplatelets in a patient who has had an infarct. But we do it if it's necessary. This is a patient who's come with a basilar artery occlusion. We find an occlusion just proximal or juxta ICA. We take a suction catheter, aspirate, and you can see this underlying stenosis over there. We take a stent retriever, When we pull it and the result looks fantastic. We nearly got a complete open vessel. Over the next 5 minutes, it occludes rapidly. Very, very good indicator that you're treating an ICAD. We run tyrofuse and look at it, the vessel looks great. We could still think of a balloon dilatation, but we did not want to do that. The plaque is prolapsing into the mouth of bilateral ICAS, and the patient has no PICAS on both sides. And you can kill the patient because of your enthusiasm of a wonderful looking angiography result. Learn this lesson. The least necessary to get the patient walking is what you should do in acute stroke. No angioplasty, the patient is fine, he's discharged 4 days after the procedure. And here is another patient. I just want to look at this angio. Can you see the tapering of the MCA? If you see this, think of ICAD. It can make a difference to your approach. When you do an MR and in the flare or in the B0 image, if you see small lacunar chronic infarcts, think of ICAD. Something has been happening which has been there for some time. When you do an angiogram, you see a mid-MCA narrowing or an occlusion with very good collaterals. Look at the collateral supply that you see over here. All these are strong indicators of an underlying stenosis. We do a suction out here. There is a stenosis that is revealed. It tends to does not open beyond that even with tyrofuse. We use a balloon catheter. We dilate it and the vessel looks good. And we will back off after 30 minutes when we see things are looking good. At this point, we do not stent unless and until it's mandatory. The last comes the fibrin clot or the heart clot. In these cases, you'll find everything mimicking the RBC clot, but the imaging will not show blooming and will not show an hyperdense MCA or a hyperdense vessel. The thing that happens inside the brain when we take a stent retriever here is interesting. The stent retriever does not allow this clot to actually impregnate within that stent retriever. So what you do is you push it to one side. When you push this to one side, you just shoulder it. A little later, it opens up and you find in the next few minutes it shuts down because this drops back. It's very different from the previous condition. And obviously, your technique of a stent retriever is going to do nothing. So the more times you run the stent retriever, the more you waste. Here today, when we suspect a fibrin-rich clot, we would use the largest aspiration catheter, and India, it's the ACE, and we will try to aspirate. And if you are lucky, it will come out. The other thing that you can attempt, which we have been trying, is this. We need a device that goes beyond it. Maybe a catch-like device will be better, but what we have been doing is this. We actually have been taking the stent retriever beyond it and pulling it backwards so it gets caught within it rather than being pushed outside it. Here is a case I want to show you. 53-year-old male, no hyperdense vessel. Can you see that? It's an acute thing. There is no chronic infarct seen. Occlusion is seen in the MCA. We take an aspiration catheter and we get a white clot. This is what I'm trying to say. Analyze what is happening rather than going for a buckshot, which you are lucky you get, or if you're not, you don't. Immediate post-procedure, this patient recovered. But sometimes you can have residual clot, and again, these are platelet-rich clots, and the best thing is to try tyrofuse out here. Here is another interesting case I want to show you. Sorry. So this patient is a patient who has mitral stenosis, AF, has been on anticoagulants, and he's clotted. The patient came to us 6 hours later. This is the perfusion and showing us a penumbra. We go ahead and do this angiogram. The ICA top is occluded. We do the double suction or the modified Solumbra technique. Can you see? The stent retriever is not opening fully. Gives us an idea that the clot is probably harder than normal. Nothing happens after the first technique. Now we take the micro more distal. And then in this, when we pull it, we get the clot. This patient also had an associated branch occlusion. Because of lack of time, I'm not showing. But I want to show you things like this, which look, if you analyze, you can get much, much better results than what you got before. And this is something we have been practicing. And we have realized over the last maybe a year, that spend time just not looking at the aspect score or if there is a bleed. Spend time to find out what do you think is the underlying pathology. And if you know what is the underlying pathology, you can customize your treatment for that pathology. And that's why I do not agree for anybody who says, 100 cases I do a suction, 100 cases I do. No, that's not the way we approach it. If a patient has UTI, I treat the urinary tract infection. If he has got an abscess, I drain the abscess. If he's got viral fever, I just give him paracetamol. And just to close, everything that glitters is not gold, and every occlusion is not a fresh clot. Thank you.
Any questions from the floor? So I have one question.
Yes.
And suppose if you have an M2 occlusion most of the time, because when we M2, so when we take out using a solitaire device, any stent retriever, when we take it out, mostly there is some intimal injury, especially in an acutely angulated M2. So
See,
how to prevent that?
Question that Uday was asking. Do we go distal when we don't have the right device? So if you have, now that we have got smaller device, for example, if I have to work on a distal MCA, I will not use anything more than a 4 mm. If it is go beyond that, I will do a suction with the devices I have at hand. I would not try anything more than that. And in all of them, I also will keep a suction catheter in the distal MCA. But we try to undersize the device and not go too distal as you pull it out.
Not too distal. The thing is, when we take out the
Yeah, there is chance.
after
Obviously,
deployment, because that acute angulation,
especially if you use a 6 mm solitaire, you will have a problem. So we don't do that. And very often we find suction works well even a distal vessel because the catheter wedges well. For example, 5 max works very often in a proximal MCA, and we use that in a proximal branch. But when it goes distal, sometimes I'll just aspirate it with a ST27. And if it doesn't work, we will do, because we don't have the right device with us. When we have the mini catch or one of these smaller vessels, we will use it because we will cause intimal damage. There's no doubt about that. So thank you so much. I should be.
Thank you, Mathew. And I think we will close the session now. And thank you very much.
Thanks a lot.